My name is Jill Berry Bowen, CEO of Northwestern Medical Center, and your host of the NMC Health Beat Show, dedicated to discussing important healthcare topics of interest to our community. Today, I'll be talking to NMC's Chief Financial Officer, Chris Hickey, and we're going to talk about healthcare reform and payment reform. It's a riveting topic, Chris, and I can't wait to hear more about this myself.
So much fun, so much fun.
So thank you for joining us
Absolutely.
again. Actually, it's great to have you back.
Yeah, no, I'm glad to be here.
Yeah, so I know folks may or may not know you because you've been on the show before.
Yeah.
But tell us a little bit about yourself before we jump in to this topic, because
Sure.
you've been with us a little while now.
Yeah, absolutely. I just passed the year mark in January, so it's been a fast year. There's a lot going on, obviously, in healthcare, but also at NMC with everything that's going on. But I've been in healthcare my entire career, dating back, I won't say a year because that'll be too long, but a long, long time, well over 35 years.
Yeah.
In New York State and also in Massachusetts, and was glad to come here back in January.
That's terrific. And I know it's you've been a great find for us too, and to be working with you and all of the experience. And you may be coming from another state, but you've spent so much time really understanding the Vermont climate. It's amazing how fast you've really acclimated to what's going on in Vermont. So,
yeah. It's
so
clearly
thank you for
unique.
being here.
Yeah, it's clearly a unique state. When I came, significant experience in New York, and most think that New York's one of the most highly regulated states in the country, and I think Vermont gives them a run for their money.
So, yeah, we are definitely want to, we want to lead in healthcare reform and this whole transformation. So, what is payment reform?
Okay.
And what is the all-payer waiver? How does that fit into this? We're hearing a lot about that, so it'd be good for the community to understand that a little bit better.
Yeah, absolutely, and it's it's clearly it can be a complicated topic, but in the basic form is healthcare for years has tried many different methodologies to try to appropriately reimburse hospitals and physicians and other healthcare providers. And the basic element of this is really to try to reduce cost. I mean, that's the ultimate. That's the ultimate reason for doing payment reform. Obviously, the governmental agencies, both the federal government and the state government, as well as the insured population, they're all trying to bend what they call bend the cost curve, and that's healthcare has been escalating significantly in terms of a cost to society over the years, and what payment reform is supposed to do is try to bend that cost curve, begin to get it to peak and maybe level off a little bit. And what it is to try to change payment methodologies that reward something other than activity. Hospitals and providers are mainly paid based on the more they do, the more they get paid. It's called a fee-for-service type of methodology. So every test, procedure that you do, you get a fee for that. A fee, that's what they call fee-for-service. You'll hear that term a lot. And the change is to try to reward other things and pay for other things like quality and the quality of care. Pay for those things to try to keep people healthy, prevention and wellness, instead of paying once somebody gets sick. So how do you keep people healthy and change the way you pay for the service? So there's a few things that different states are trying different things, but the key element is to try to change it to be more based on a whole combination of care provided to an individual versus a single episode or that fee for that single service.
So is that what the all-payer waiver is trying to accomplish? And
yeah, the all-payer waiver really, the federal government came up with a methodology several years ago to and it's an acronym that's used as APM, which a lot of people think that's all-payer waiver. It's really alternative payment methodologies is what APM, if you hear it in the news, really stands for. And the federal government has designed, it has passed laws that really encourage states and providers to participate in an alternative payment model. The state has been very proactive. The state of Vermont has been very proactive in relationship to seeking approval from the federal government to be able to participate and form really an alternative payment methodology. And last October, actually, this past October 2016, the state actually signed on with the federal government, Centers for Medicaid Services, CMS, and to actually provide an alternative payment methodology. And we're still working on that. We're still working on that. It's a multi-year agreement with them. Actually, 2017 is what they call year zero. And year zero is kind of a planning and development year for the true all-payer model implementation, which occurs in January of 2018, and then runs 5 years. It runs from 2018 all the way through 2022. It's not fully designed what it will ultimately look like, but what in essence it's going to do is limit the growth in healthcare in the state of Vermont to be lower than the national growth in healthcare cost. It may sound insignificant, but it's 0.2%. We have to be below 0.2% of what the federal government growth is. But if the federal government can get every state to not grow by 0.2%, that's a pretty significant impact, across the country. Now, the way the state is ultimately going to do it is likely in a capitated agreement. And what does capitated agreement mean? It means that the government will pay the hospital a certain amount of money per individual on a monthly basis for the care that's provided to them, regardless of how much care they have provided to them. Where it used to be every time I went for a lab test or an x-ray or whatever the procedure might be, the hospital would get a fee. Now they give me one lump sum fee that I get over time, and I've got to make it work for that individual. Some individuals you'll make out on, some individuals you won't make out on.
Right.
And that's where risk comes into play, because what's really happening is it's a shift of risk from the federal government, from the state government, and from insurance carriers. It is shifting some of that risk for the management of the health care of the population to the hospitals, which
Absolutely.
is the scary part from a
It is.
CFO's perspective of an alternative payment methodology.
So no matter where that patient goes, that one capitated amount covers the care for that
Correct.
patient.
Yeah, correct.
So whether it's a hospital service or primary care or home health, is it all inclusive?
The only part that there's a couple things that are still excluded from it. Pharmacy is excluded from it because pharmacy is one of those. It's probably the use the word scary from the perspective of it's unknown and constantly changing. Which that's a good thing about pharmacy. They're constantly finding new treatment methodologies, new drugs that can treat, things like cancer and other diseases. So they've carved that out for now. And I'll say for now because I think eventually they want to find a way to include pharmacy in this whole capitated model, but not anytime soon. And long-term care currently is also a piece of that. So if you have to go into a nursing home, that's excluded at this point in time.
So we're involved in a pilot.
We are.
Can you describe that a little bit?
Well, what I just described applies to really all payers. The agreement we signed in October, or the state of Vermont signed, is for Medicare. Okay?
Yes.
But we've also participated in a pilot that you mentioned for Medicaid. So Medicaid is the state-based components for those individuals, needy individuals within the state of Vermont, and we've agreed to participate in a program called Vermont Nextgen, and Vermont Nextgen is an agreement that was crafted between our accountable care organization, which is One Care Vermont. An accountable care organization is an organization that spans over several hospitals and several healthcare providers to kind of be the focal point or the center point to be able to negotiate contracts and to be able to negotiate with the state. And One Care Vermont has negotiated with the state of Vermont this Vermont Nextgen initiative. And it's really the same thing that Medicare is doing. It's really changing reimbursement methodology from that fee-for-service, which is the way Medicaid was paid historically and still is paid for many providers, and a capitated agreement. There's 4 hospitals, 4 communities, and specifically 4 hospitals across Vermont that have agreed to participate in this pilot. Northwestern Medical Center being one of those. University of Vermont Medical Center, Central Vermont Medical Center in Berlin, and Porter Hospital in Middlebury, Vermont. So the 4 of us have agreed to take on an element of risk in a capitated environment to provide health services to Vermont Medicaid individuals.
Okay. So how are we positioning ourselves to work in a capitated environment? Are we looking at the cost of healthcare? So is it the business as usual, or
absolutely not?
How do we prepare for this and maybe tell the community what we are trying to do?
Yeah, absolutely. And this will be a perfect topic for you to bring somebody else on this show, because you know the most important part about this whole transition from fee for service to capitation or an alternative payment methodology is care coordination. And really, care coordination is developing a model to really be for your healthcare provider to be very involved in relationship to your healthcare. So depending on what underlying circumstances you may have from a health perspective, we really set up a model that really reaches out to people. So there's the healthy population, which you may reach out to once a year, and then there's the low-risk population that you might be reaching out to 3-4 times a year, and then there's the high-risk population that you might be reaching out to 7 or 8 times a year, and then there's the chronic sick population, you know, that you're probably reaching out to monthly or even maybe more recently than monthly. And you know, it's really helping. It's making sure medicines are being taken. It's making sure they're doing their routine healthcare issues. So that's care coordination.
Yeah.
Most important part of care coordination is really prevention and wellness, and the element of prevention and wellness, and how prevention and wellness is going to bend the cost curve. That's going to take years to do, but really the key is, how do you get people to be well and prevent them from getting into bucket 2, 3, and 4, and keep the higher group of population that we can have in that level 1, who's healthy, who's having their annual physical, who's having physical activity, who is eating well, and all those things that go along with prevention and wellness. Pretty interesting for a CFO to be talking about.
I know. I was thinking about that as I was sitting here. This is fantastic to be hearing about this. And the hospital, the traditional hospital for treatment of disease and acute incident, is really, transitioning to really focus on wellness and prevention.
Yeah, and the challenge really is, and the reason why wellness and prevention hasn't been as front and center as it really should have been for years. Prevention and wellness should have been front and center, 30, 40 years ago.
Absolutely.
Is nobody was paying for it. And still, that's the challenge today. The challenge today is that, the healthcare system hasn't been designed historically to pay for wellness and prevention. It's been designed to pay for sick people. It's been designed to pay for people once something has already happened. And there aren't really good payment methodologies to be able to say, hey, I'm willing to invest in wellness and prevention. That's one of the things I love about NMC, is because NMC is willing to invest that money, is willing to reinvest in prevention and wellness. The reward is probably going to take years to actually get. before that curve that I mentioned earlier, is that cost curve is really going to start to bend. But you've got to invest in that prevention and wellness to be able to make that happen. In a capitated agreement, it makes it a little bit easier to do because you're given the money and you're told you invest it the way that you think is best for health care. Our challenge is going to be, fitting the pieces of that puzzle together and saying, here's how much we can do in wellness, while we still have to invest all those dollars to treat those people with chronic disease and those people with issues that have to be dealt with on a month-to-month and day-to-day basis.
Wow. It's a huge, cultural transformation, not only for the hospital, but for the community as well.
Yeah,
so
absolutely.
That's fantastic. I wish we had more time, but the time is gone.
Wow.
So I can tell you're going to be back, or we're going to be talking more about this and
Sure.
The impact to local healthcare, as well as how this plays out over the years that you have mentioned, since we're in year zero.
Yeah, year zero.
And we're a pilot. How's this all going to play out?
Yeah, absolutely.
So thank you again for being on our show, and it's going to be interesting, how this plays out. But I want to reassure the community that we're a very strong organization, and what makes us strong is the partnerships that we have across our community. As Chris talked about care coordination, it's not just about Northwestern Medical Center, it's about all the care partners across our community, and we couldn't do it without the support of this community. So I'm Jill Berry Bowen, your host of the NMC Health Beat Show, and so grateful that you were here with us to listen and learn about payment reform and what it means to us locally. And Chris, thank you again. It's really been fun and riveting.
Absolutely.
Sure. Thank you.
All right, you're welcome.